associate professor from the Department of the Radiation College of the Cancer Hospital, Chinese Academy of Medical Science. So she had been working mainly on the magnetic resource guided radiotherapy and radiotherapy planning, optimization, and automation. So if you during this webinar, if there are any questions, please paste your questions on the chat box. So now welcome Dr. Chen Jiayun to host this webinar. Dr. Chen, the no voice, Dr. Chen.
So can you hear me?
Yeah, now can.
Okay. Let me introduce our speaker today. He is a very talented medical physics, now working in the Department of Radiation Oncology, Physics and Techniques, Proton Center at the Shandong Cancer Hospital. He also assistant chief in the department, and now he engaged in the clinical research working on proton, heavy ion, and flash radiotherapy. That's a very hot topic. So let's warmly welcome our speaker, Dr. Tianyuan Dai. Please share your screen.
Yeah. Thank you, Dr. Jin and Dr. Chen. And hello, everyone. Good morning and good afternoon. To those who don't know me, this is Tianyuan Dai from Shandong Cancer Hospital, and I'm a medical physicist at the Department of Radiation Oncology, Physics and Technology. My background includes proton therapy, heavy ion therapy, and flash therapy. And today's topic is recent progress in proton and heavy ion therapy. This figure shows the statistics of patients treated in particle therapy facilities worldwide. As of April 2024, over 365,000 people worldwide have received particle therapy, which includes treatment with protons and heavy ions. Among these, proton therapy is the most widely available and frequently used. Heavy ion therapy, while less common, has also been seen steady growth, particularly in Asia and Europe. In our center, we treated over 20,000 patients each year. Among these, about 1,200 patients were treated with proton. So it can be seen that proton and heavy ion therapy only account for a very small percentage of radiation therapy, but the increase, as shown in the figure, reflects the global expansion of particle therapy centers, with new facilities emerging across worldwide. And more centers are developing their capabilities for both clinical treatment and research. Compared with X-rays and gamma rays, Bragg peak is the most important advantage for both protons and heavy ions. Besides, protons also have other advantages, such as the lateral scattering is small and there is no dose after the Bragg peak. These properties allow proton beam to reduce the exposure to organs at risk, such as lungs, heart, esophagus, and spinal cord, and reduce the risk of radiation on children's growth and the probability of radiation-induced secondary malignant tumors. For heavy ions, there are many other advantages, such as the high relative biological effectiveness, RBE, which can greatly reduce the possibility of radiation damage repair, and the low oxygen enhancement ratio, OER, and the short treatment course, range online monitoring, and narrow lateral scattering with high precision. And there's no dependence of cell radio sensitivity on cell cycle. The narrow pencil beam produced by proton or heavy ion accelerators cannot be used to treat patients directly, since the narrow Bragg peak cannot cover the tumor volume in both lateral and longitudinal directions. So the beam should pass through a beam delivery system to create a field with certain size laterally and spread out Bragg peak longitudinally. There are mainly two kinds of beam delivery systems in proton and heavy ion therapy. Passive beam delivery system as shown here, and the active beam delivery system in the next page. In passive beams, in the passive beam delivery system, the first scatter and second scatter are used to spread the beam laterally to form a field. The ridge filter here is used to spread out the Bragg peak longitudinally. The dynamic picture here shows the rationale for the creation of SOVP. The binary range shifter here is used to modulate the beam range based on tumor location. Collimator and patient-specific bolus here is used to dose conformal. It should be noted that although the passive beam delivery system is old technique, it works well in eye tumor treatment and can mitigate the interplay effect caused by anatomic motion. Now, the most new protein and heavy ion centers are equipped with the active beam delivery system, and this is a continent method with only two scanning magnets to achieve the beam delivery to the tumor. In terms of the dose conformity, the active beam delivery system works much better than passive beam delivery system. What's more, there's no need to manufacture the patient-specific components, which usually take several days before treatment. And this dynamic figure shows the rationale for the active beam delivery system in protein and heavy ion therapy. In the following, I would like to present something about the current clinical practice in protein and heavy ion therapy. Compared to the X-ray radiotherapy, there are several points that additional attention need to be paid. First one is the setup uncertainty. Since the delivery of protein and heavy ion beam to tumor is sensitive to setup uncertainty, therefore it is highly recommended to equip the device for image guidance before treatment. The setup uncertainty should be controlled as small as possible. At the same time, a setup uncertainty of 3 millimeters for head and neck patients, or 5 millimeters for thoracic or abdomen patients should be considered in the treatment planning system. Another critical issue in protein and heavy ion therapy is range uncertainty. Protein and heavy ion interact with tissue differently from that of photon. This results in the extreme sensitivity of range in protein and heavy ion therapy. For example, as shown in the figure, a 3 centimeters range variation will decrease the dose by 11% for photon. However, this will decrease the dose by 100% for protein and heavy ion beam. This figure shows how range uncertainty affects the tumor target coverage and normal tissue protection in protein and heavy ion therapy. In clinical treatment, protein and heavy ion therapy should not point to the critical OER, such as the brainstem or spinal cord. As shown in the right picture, it can be seen that the nominal distribution of the plan could protect the spinal cord very well. However, when 3.5 range uncertainty is applied, the spinal cord will be covered by the high dose cloud. To overcome the setup and range uncertainty in protein and heavy ion therapy, there are several tips in clinical practice, such as we need to avoid the beam direction with the path of highly heterogeneous tissue and set the proximal and distal beam specific margins along the beam path and considering the smearing effect. And we can utilize the beam specific PTV or a robust target volume RTV, or we can use a dual energy CT, and this is a research direction and need to be further explored in the following. And what's more, with the development of robust optimization in treatment planning system, the setup uncertainty can be taken into account to the plan optimization during the treatment planning. The corresponding parameters such as the 3 millimeters setup uncertainty and the 5 millimeters setup uncertainty and the 3.5% of the range uncertainty can be set. This is an example shows how robust optimization works. in the right picture, the setup uncertainty of 5 millimeters are set in X, Y, and Z directions. Considering both positive and negative values are possible, this results in 6 scenarios. And then considering the range uncertainty of 3%, also both positive and negative values are possible. This will result in 2 scenarios. 6 multiplied by 2. There are 12 scenarios in total that should be considered in the plan optimization. The robust optimization will result in a robust Proton or heavy iron plan. To perform the robust evaluation after the plan optimization, we should calculate the DVH curves for all 12 scenarios with various range and setup uncertainties. Then both the dose coverage and of the tumor target and the risk of OARs can be evaluated considering setup and range uncertainty. This is an example for the robust evaluation according to the DVH curves calculated for all possible scenarios. Plan robustness can be evaluated by physicians and physicists. And up to now, it can be seen that the setup uncertainty and range uncertainty have already been figured out very well through the newly developed method in treatment planning system. In the following, we will talk more about the issues that have not been fully figured out. The anatomy here is the anatomy uncertainties. As shown in the left figure, this is the patient anatomy during CT simulation and treatment planning, and in the right figure, this is anatomy during treatment. If the plan is delivered, the dose coverage of the tumor is poor, and this will result in a failure of tumor control. Such as the gas cavity, metal implants, and the shrink of tumor. These are common anatomy uncertainties during treatment. To mitigate the effect of anatomy uncertainties, several approaches could be investigated, such as the adaptive treatment, or avoid beam angle with large uncertainties, or a multiple field plan, or gas volume overrides. These are all methods to mitigate the anatomy uncertainties in our clinical practice. The image-guided or adaptive proton and heavy iron treatment is an interesting topic in recent years. The application of both CBCT and CT on rail can be considered. As shown in the table, several issues still need to be figured out, such as the low CT image quality for CBCT and the precision of coach monitoring for in-room CT and so on. The ultimate method of in-room imaging may also be Proton CT. Proton CT can not only provide a isocentric patient geometry, but also directly measure protein decay in the patient's body, thus reducing the uncertainty of range. A major technical difficulty for this method is that the large scattering along the beam path creates a limitation on the spatial resolution of proton CT. The interplay effect in proton therapy refers to the interaction between the motion of the target and the dynamic delivery of the proton and heavy iron, and the dynamic delivery of the proton and heavy iron beams. This effect can cause the variations in the delivered dose distribution compared to the planned dose, which potentially leading to the underdosage of the tumor or overdosage of the healthy tissue. The interplay effect is particularly significant in the treatment involving moving targets, such as lung tumor in the upper figure. Strategies to mitigate the interplay effect mainly includes these 4 methods. Rescanning. Rescanning is repeatedly delivering the same treatment field to average out the motion-induced dose variations. Gating here is the synchronizing beam delivery with specific phases of the respiratory cycle to target the tumor only when it's in a defined position. And the active tracking is the real-time adjustment of the beam to follow the tumor's motion during the treatment. And the fully robust planning is to incorporate the time-resolved 4D images into the treatment plan to account for the tumor motion and ensure dose accuracy across all motion phases. 4D robust is an interesting topic this year. Many treatment planning systems support this function. Here is a research on the 4D robust optimization conducted by our group, which studied the effect of breathing phases number on the 4D robust optimization for pancreatic cancer intensity modulated protein therapy. Another hot topic is spatial frictionated radiation therapy, SFRT. It started from the 2D grid therapy. The aim of SFRT at the beginning is to better protect the normal tissue. And now, the 3D IMRT and VMAT techniques allow the lattice therapy using X-rays, and better tumor control were reported. Now, many proton and heavy ion centers are developing the SSRT methods using proton and heavy ion beams. This paper showed the application of proton grid therapy on large tumor treatment. This is the proton lattice therapy experience from Mayo Clinics, as shown in the red figure. It can be seen that proton works better than X-rays, and it can be seen that the proton SFRT, especially proton lattice therapy, is a promising approach to control the large tumors. There are only limited up to now. There are only limited experience that can be referred to, and in the future, there are many directions that need to be further investigated, such as the proton mini beam or microbeam therapy, the radiobiology for the SFRT and SFRT and immune responses, and the tumor types that could benefit from SFRT. Here presented is the SFRT case at our center. The patient was treated with three frictions of 10 gray RBE at the GTV peak, and 15 frictions of 3 gray RBE at the GTV valley. This is the CT. Here is the CT images before treatment, and here is the CT images 1 month after the treatment. The tumor, as shown in the figure, the tumor shrinkage is very obvious. The field of proton or heavy ion arc therapy has developed a lot recent years. The energy layer switching is the main challenge for proton or heavy ion arc therapy. What's more, the stability of the equipment and the safety interlock or QA devices are also further research directions. Here is a multi-ion particle therapy. Presently, proton and carbon ions are the leading ion therapy modalities. However, neither of them can be considered the perfect particle, and the determination of which particle is best suited for a particular treatment is circumstantial. With the new system at QST in Japan and the new facility at HIT in Germany, multi-ion particle therapy is possible now, and this provided a more effective way for tumor treatment. Next topic is RBE. RBE is always an important topic in proton and heavy ion therapy. RBE is defined as a ratio of the physical dose of the X-rays to the physical dose of proton or heavy ion dose that's required to achieve the same biological endpoint. The influencing factor of RBE are very complex, such as the particle type, LET, and endpoint and radiosensitivity of the cells, or cell cycle and friction dose, or alpha beta ratio, and so on. Why the concept of RBE was introduced in proton and heavy ion therapy? That is because in photon radiotherapy, through the accumulation of a large number of treatment experience in the past more than 100 years, physicians have already known very clear about the tumor prescription dose and the dose limit of normal tissue. However, for proton and heavy ion beams, it is not clear. RBE is the key to convert the proton and heavy ion dose to photon equivalent dose. On the other hand, the high RBE at the Bragg peak can kill the tumor cells more effectively. And on the other hand, it is difficult to quantify RBE accurately. It can be said that accurate quantification of proton and heavy ion RBE is an important prerequisite for clinical treatment. For proton and RET, for proton, the RET increases with the increasing of penetration depths, and this results in a relative high RBE at the distal range. For proton, the dependence of RBE includes RET and the rise of the SOVP and the friction dose and alpha beta ratio. According to the APMTG 256, it is still recommended to use a fixed value of 1.1 for RBE in proton therapy in clinical practice. And now, many treatment planning systems are developing the function of RET optimization. This can locate the high RET region into the tumor for better tumor control and distribute the low RET region to the normal tissue for better OAR protection. For heavy ion beams, the RBE becomes extremely complex since the value of RBE for heavy ion range from 1.1 to 3 or 4. Therefore, models for RBE calculation is needed in heavy ion therapy. In 1990s, the mixed beam model was developed in Japan, and this is used for the further treatment of patients using carbon ions in mirrors in Japan. Then the microdosimetry kinetic model was also developed and applied to the clinical treatment in Japan. This is a microdosimetry-based RBE model. The local effect model is an RBE model that developed in Germany, and our REM model and MKM model are the two mainstay models are now in proton and carbon ion therapy. And this is an RBE model called logistic nanodosimetry model, which was developed by me and my supervisor when I was a PhD student. At last, the flash therapy, as most of you may know, can be achieved by proton or heavy ion beams. The first method is to shoot through. The first method is the shoot through approach that utilize the plateau region for the treatment with flash dose rate. Another method is the Bragg peak approach. This paper described this normal approach. If you are interested, definitely download it, and it talks a lot about the Bragg peak approach for flash dose rate beam delivery. The challenges and also the future research directions could be the dose delivery and treatment planning for flash therapy with proton and heavy ion beams, or dose measurements, or dose rate evaluation. In our center, a research room that is flash capable has also been prepared, and our center is a member of Flash Forward Consortium, and more flash work will be done here. This is a summary of today's presentation, and we talked a lot about the basics for proton and heavy ion therapy and the current clinical practice for proton and heavy ion therapy, and how to solve the anatomy uncertainties in the following in the following, and the interplay is how to mitigate the interplay effect, and the spatial frictionated radiation therapy (SFRT), and the proton or heavy ion arc therapy, and multi-ion particle therapy, and RBE in proton and heavy ion therapy, and how to use the proton beam and flash and the heavy ion beams to achieve the flash beam delivery under a flash dose rate.
Thanks you for presentation, Dr. Dai. And there are two questions from FAQ. First one is, to what extent to develop anomalies or genetic mutations to lead to variation in organ structures and locations?
Yeah, that's a good question. Since in proton and heavy ion therapy, the locations of the tumor also differs from one fraction to another fraction. So we need to include the robust optimization, including the setup sensitivities and the range sensitivities. Only these two factors are taken into account in the treatment planning. We can mitigate this the sensitivities effect on the dose coverage of the tumor and the protection of the normal tissue.
Okay, the second question is, how does the interplay effect differ in its manifestation between the static and dynamic beam diverse systems such as MRT and VMAT?
Yeah.
That's out of the topic today, but you can give us more hint.
Yeah, as in clinical practice, in photon therapy, we use X-rays for the MRT or VMAT. The motion of the multi-leaves are also dynamic, but photon rays or X-rays are not sensitive to that. So you can always realize a wonderful dose coverage of the tumor target, although there's a dynamic dose delivery in VMAT and MRT. But in proton and heavy ion therapy, the broad peak position is very sensitive to the patient anatomy changes, and this will result in extremely sensitive for proton and heavy ion therapy, considering the interplay effect between the dynamic beam delivery and the tumor motion or patient respiration.
Okay. There was another question from the machine. How is the PSQA performance for proton center, and which dosimetry equipment are recommendation for analysis patient-specific QA? That's a good question.
Yeah. For patient QA, we use in our center, we use a facility, or we use an equipment called the Matrix PT, and there's we can insert we can insert this equipped in a water tank, and this water tank can move this equipment at each depth, so we can use it to measure the dose map at each depth of in the water tank.
Mm-hmm. Any other questions? Because Dr. Dai will give a talk in another conference, that's the offsite meeting. If there are any questions, one more. Which material is MLC made up in proton therapy? That's the last question.
Yeah, most up to now in our center, we use the active beam delivering system. So in various facilities, there's no MLC for the proton facility. However, for some other facilities, such as the Marians or other heavy ion facilities, they use some materials such as kinds of tungsten or some materials to manufacture the MLC.
Mm-hmm. If you have any questions, you can maybe email him. Oh, one more promotion. Okay, that's the last one, please. Is there a need for bolus for proton therapy, and what is the limitation?
Yeah. For proton therapy, since the lowest energy for proton accelerator always be 70 MeV, and its range is about 5 centimeters. So if you want to treat the patient, treat the tumor that with shallower location, we need to use a device, but it is not called bolus. We call it range shifter, RS range shifter. The range shifter why it is not called the bolus, since it was inserted in the treatment head, not put on the patient body. So yeah.
We must say goodbye to everyone now, because Dr. Dai will have another talk offline in maybe in 15 minutes, right? Yeah. Okay. If you have any question, please email him. Okay. And don't forget to, if you want to CPD certification, Dr. Iran already posted a link here. Please don't forget to click it and fill the form. Thank you very much. And everyone have a good day today. Okay, bye.
Bye, see you.
See you. Thank you.